Hi guys, today we'll move with the topic induction of labor. Induction of labor is to initiate the process of labor in a quiescent uterus. That is, there is a difference between spontaneous labor and induction of labor. In induction of labor, we are artificially inducing the process of labor. What is augmentation of labor? It is to accelerate the process of labor in the uterus which is already in contraction. What are the indications? Pregnancy induced hypertension. Mild preeclampsia will be doing at 37 weeks. Severe preeclampsia will be doing at 34 weeks. In case of eclampsia and HELP syndrome, we'll be doing it immediately. In case of premature rupture of membrane rupture after 37 weeks but before labor. So in such cases, we have to do immediate induction of labor. In case of preterm premature rupture of membrane, we'll be doing the rupture will be happening less than 37 weeks. So we'll be doing it 34 weeks. So we'll be doing it at postterm pregnancy immediately because the days already crossed greater than 42 weeks. In case of abruptio placenta, we'll be doing it immediately. In case of chorioamnionitis, we'll be doing it immediately. In case of oligohydramnios, we'll be doing it 36 weeks. In case of oligohydramnios, along with IUGR, we'll be doing it at 34 weeks. In case of gestational diabetes, we'll be doing at 39 weeks or lesser. In case of RH isoimmunization, if severe anemia is present and the peak systolic velocity in middle cerebral artery Doppler is greater than 1.5 multiples of meridian, we'll be doing it at 34 weeks. If the peak systolic velocity is less than 1.5 multiples of meridian or the antibody titer is less than 1:16, we'll be doing it at 37 weeks. In case of RH negative pregnancy, if the indirect Coombs test is negative, we'll be doing it at 40 weeks. We'll not let to cross the pregnancy beyond the expected delivery date. For induction of labor, it is necessary to check the status of cervix before induction of labor. How to check the status of cervix? We use Bishop score. There are five parameters in the Bishop score, that is dilatation of cervix, position of cervix, effacement of cervix, station of fetal head, and consistency of cervix. In case of modified Bishop score, the length of cervix is used instead of effacement of cervix. How to score? For position, normally the uterus will be anteverted and anteflexed. So for the position, if it is present posteriorly, we'll give 0 score. If it is in mid, we'll giving 1. If it is present anterior, we'll be giving 2. Coming to the consistency of cervix, if it is firm, you give 0. If it is medium, you give 1. If it is soft, you give 2. Coming to the dilatation of cervix, it's an important. If there is no dilatation, you give 0. If it is 1 to 2 centimeter, give score of 1. If it is 3 to 4 centimeter, give score of 2. If it is greater than or equal to 5 centimeters, give score of 3. Effacement of cervix. You remember the score 30, 50, 70, 80. For the up till 30%, give score of 0. For 40 to 50%, give score 1. For 60 to 70%, give score 2. For greater than or equal to 80%, give score 3. Coming to the station of it, an important landmark is ischial spine. The station is 0 at the ischial spine. If it is at the uh, 3 or -3 or above, the head is at the -3 or above, you give score of 0. If it is in the -2 level, give score of 1. If it is in the -1 or the 0 level, we give score of 2. If it is in the positive levels, give score of 3. Maximum Bishop score one can obtain is 13. If the score is less than or equal to 5, it is a poor score. First, you have to ripen the cervix then. If the score is greater than or equal to 6, you can in, do induction of labor. But if the score is greater than or equal to 9, maximum success of induction of labor is there. As I said, in modified Bishop score, assessment is replaced by cervical length. If the cervix length is greater than 4 centimeter, give score 0. If it is 2 to 4 centimeter, give score 1. If it is 1 to 2 centimeter, give score 2. If it is less than 1 centimeter, give score 3. Bishop score is done clinically, whereas modified Bishop score is done with the help of ultrasound. Most commonly, we'll do clinically, that is a Bishop score, but more accurate one is modified Bishop score. What are the drugs used for induction of labor? It is prostaglandin E1, misoprost. Dose is 25 micrograms per vaginally for 4 hours, 6 doses. Remember the dose, it is 25 micrograms. What is the dose in case of postpartum hemorrhage? It is 800 micrograms. What is the dose in case of active management of third stage of labor? It is 600 micrograms. And prostaglandin E2 or dinoprostone cerviprime gel is used. Dose is 0.5 mg intracervically for 6 hourly. 4 doses will give. Now, this prostaglandins are not used in patients with previous LSES. Induction of labor is not contraindicated in heart disease patient and not contraindicated in previous cesarean section patient. Do not confuse it with use of prostaglandins. Prostaglandins are contraindicated in previous cesarean section patients, but induction of labor we can use another methods. Cervidil, dinoprostone 10 mg. It is kept in the posterior vaginal fornix to allow slow release of the drug. You have to remove it after 12 hours or earlier if the contraction begins. Mifepristone or antiprogesterone or RU486. You have to give 200 mg per vaginally. Oxytocin can be used for both inducing and augmentation of labor. Mechanical methods: Polish induction or transcervical balloon catheter. You have to infuse saline in the Foley's catheter. After the bulb is filled, the extra fluid will be moving on to the extra amniotic fluid space. That we call it as extra amniotic saline infusion. Basically, you have to put the Foley's catheter in the uterus. You have to distend it with normal saline, 30 to 50 ml, and you have to pull down at the level of internal os. Next method is stripping of the membrane. It is an OPD procedure. You have to sweeping and stretch the membrane. You don't have to rupture, you have to sweep and stretch the membrane so that prostaglandins are released and it will initiate uterine contractions. Hygroscopic dilators are obsolete. These are used in abortion, not used in term deliveries. Contraindication for induction of labor is equal to contraindication for vaginal delivery. Severe CPD, contracted pelvis, malpresentation like transverse lie, brow, oblique, and face with mento-posterior presentation, fetal distress or non-reassuring fetal status, placenta previa, classical C-section or previous 3 C-section, previous hysterotomy or previous myomectomy, active genital herpes infection, drugs for augmentation or oxytocin, artificial rupture of membrane, using Kocher's forceps. We can identify Kocher's forceps as it will be having two teeth on one side and one teeth on the other side with serrations. Use of amniocords. Amniocords are glove with needle at the tip. What are the advantages? They increase uterine contraction. We can see the color of the amniotic fluid. If it is green in color, then it is the fetus is in distress. It decreases bleeding in case of abruptio placenta. As it leads to uterine contraction, it decreases bleeding. What are the risks? The risk of prolapse is high if artificial rupture of membrane is done in free floating head. So you should not do an free floating head. The head should be fixed. Risk of infection and risk of trauma. Avoid artificial rupture of membrane in case of free floating head, intrauterine death of fetus, HIV of female, active genital herpes infection. In case of polyhydramnios, if you do artificial rupture of membrane, the size of the uterus will be suddenly shrinking. So there is risk of separation of the placenta that we call it as abruptio placenta. So what we do? We do controlled rupture of membrane in such cases. You have to introduce the needle into the vagina and you have to make very small hole so that fluid will be trickling. In but the membranes will be tensed usually. So there may be a chance that entire amniotic fluid might be coming out. So if in such cases you have to introduce a sterile pad on the vulval outlet to control the outflow of the amniotic fluid by using controlled movement of hand, which will be preventing sudden decompression of the uterus. So that will be preventing abruptio placenta. Okay, that's all for today. Thank you.